Hello, my name is Doreen. Thank you for joining me. This is your clap on individualization of antiplatelet therapy with CYP2C19. A quick overview of pharmacology of oral P2Y12 inhibitors. The class of thienopyridines is represented by clopidogrel and prasugrel. The green circle depicts the functional group which confers similar mechanism of action to the two. Ticagrelor belongs to a class of cyclopentyl triazolopyrimidine. Some have given it an understandably easy to pronounce name of non-thienopyridine. Here's a comparison of oral P2Y12 inhibitors. Firstly, clopidogrel and prasugrel irreversibly block the P2Y12 component of ADP receptors on the platelet, resulting in reduced activation and aggregation. Ticagrelor, on the other hand, reversibly and non-competitively binds at the same site. Secondly, prasugrel and clopidogrel are prodrugs requiring CYP enzyme bioactivation into the active drug, while ticagrelor does not require biotransformation. Let us dive deeper into the quirks of these agents. Prasugrel and ticagrelor are more likely to be associated with bleeding compared with clopidogrel. Notably, do remember that ticagrelor is associated with additional adverse effects like dyspnea and bradycardia, common reasons leading to patients' rejection of the drug. When prescribing prasugrel, one must note key characteristics which modify dosing. As for clopidogrel, more on its resistance in the subsequent slides. So, why is CYP2C19 polymorphism such a big deal? Well, clopidogrel requires a two-step bioactivation before it is active. 2C19 is involved in both steps. When one carries a STAR2 or STAR3 allele, they are termed loss-of-function carriers. If one has a STAR17 allele, they are called gain-of-function carriers. CYP2C19 loss of function is associated with a higher risk of adverse cardiovascular events following percutaneous coronary interventions or PCI. Phenotype classifications are derived from permutations of the alleles which an individual carries. If one uses a guideline, CYPIC or similar, one would find the recommendation for the consideration of ticagrelor or prasugrel use in intermediate or poor metabolizers. Now, there are two recent clinical trials which are worth discussing. Popular use CYP2C19 information to de-escalate non-loss-of-function individuals from ticagrelor or prasugrel to clopidogrel. Conversely, Taylor used a strategy where loss-of-function individuals were escalated from clopidogrel to ticagrelor or prasugrel. Genotype-guided groups were compared with standard care in both studies. The primary endpoint for both involved reductions in adverse cardiovascular events. While it was a 23% statistically significant reduction in net adverse cardiovascular events for Popular, the major adverse cardiovascular events or MACE rate was not significantly different between groups in Taylor. Taylor was underpowered. We must not go away thinking that we should disregard the finding of the study. The effect size of 34% reduction in MACE is too remarkable to ignore. Furthermore, the absolute risk reduction of 1.8% is similar to that seen in Plato. If we could accept labeling of ticagrelor based on Plato, why shouldn't we consider genotype-guided selection of P2Y12 inhibitors? Furthermore, genotype-guided de-escalation was shown to reduce bleeding significantly in Popular. Would this not present an attractive option to any prudent clinician? Further to the earlier RCTs, investigator of Taylor went on to meta-analyze almost 16,000 acute coronary syndrome individuals, 77% of whom received PCI. Pereira et al. Found that the use of ticagrelor or prasugrel in CYP2C19 loss-of-function carriers was associated with significant reduction in ischemic events, whereas for those who were non-loss-of-function, it wouldn't make a difference even if clopidogrel was used. The p-value for interaction was statistically significant, suggesting the impact of CYP2C19 on the outcomes observed. In Galley's meta-analysis in The Lancet, it is clear that MACE and minor bleeding outcomes favor the genotype-guided strategy. The genotype-guided strategy was consistently favored whether it involved ischemic outcomes in escalation or bleeding outcomes in de-escalation. The Lancet meta-analysis was accompanied by a comment from Sibing himself in the schema, suggesting that thrombotic and bleeding risk factors should be considered along with genotype testing in the tailoring of P2Y12 inhibitor for an individual. This was the very rationale for the I Write For Me schema, first conceived by the Khoo Teck Puat Hospital team and now spread to the National University Hospital and Ng Teng Fong Hospital in Singapore. Here, we create an algorithm which involves ischemic and bleeding risk factors along with CYP2C19 testing with a plan for escalation or de-escalation in the respective subgroups. So that was your clap on individualization of antiplatelet therapy with CYP2C19. Thank you for listening.